Good evening all to the 88th session of the Weekly Huddle. I am Anoop and joining me today is my friend and co-host Praneeth. We are cardiologists working at Care Hospitals. Most of you know the format of the Weekly Huddle, so we are just gonna get to our today's discussion. Just that once a while in our discussion, we pick up a clinical topic and then sometimes we pick up a clinical case, understanding that topics are a little bit more streamlined versus cases are something where we need to discuss about that particular case rather than topic in general. So today we will be discussing a clinical case that will, will cover a lot of topics that we do have to make decisions in our day-to-day clinical practice. But we'll try to reserve our discussion around this particular clinical case while we'll try to cover the topics which are part of today's case discussion. So having said that, I'll start this clinical case, and once I'm done, I will ask my co-host Praneeth to give his initial impression, and then we will take opinion from our attendees as well. As always, if you do have any questions or if you do want to add anything, you can either raise your hand or you can post it in the chat box and I will bring it up for discussion. So the case for today goes as follows. It's a 52-year-old male. I actually saw him in the OPD today itself. This guy, and I'm seeing him for the first time, this guy underwent PTCA to mid-LAD around 4 years back. So at that time, he was 48 years of age. And that time, the PTCA was done because of non-ST elevation MI. I looked into his previous records, and at that time, he presented with chest discomfort. His ECG showed some non-specific changes. Echo was normal. His troponin was significantly positive. So he underwent an angiogram, which showed almost subcritical stenosis of the mid-LAD, which underwent uneventful stenting followed by a 2-day hospital stay. He was discharged since then and he had been doing all right. So that was around 4 years ago. He was under regular follow-up for about 2 years. And in the last 2 years, he calls it for COVID, but in the last 2 years, he has not seen any cardiologist or any general physician for his medical issue. Although he did continue taking the medications which were prescribed to him last, that was around 2 years ago. He's a non-diabetic. His cholesterol levels were slightly elevated earlier. And as I said, in the last 2 years, he has not got it checked. He used to smoke before his stenting procedure, which he claims that after his PCI, he has stopped smoking. So his today's visit was a pretty much routine follow-up. He didn't have any complaints. He just said it's been such a long time and I have not taken any medical opinion. So now here I am. And he actually came to me with a lot of investigations. He probably got like a package or something done. So he just came to me with a lot of such investigations. He didn't have any complaints. The blood pressure that I got in the emergency in my OPD was 104/68 with a heart rate of 66. His physical exam was non-remarkable. In his basic workup, I'll just give you a brief summary, and then if you have any particular questions, I can answer that. His hemogram and renal parameters, including electrolytes, were all normal. His ECG and echo were also normal. His lipid profile showed a total cholesterol of 146, HDL of 42, LDL of 62, and a triglyceride of 99. All these numbers I have posted on the WhatsApp group in case if you want to review that. His HbA1c was 5.9. Those were most of the labs that he got when he came to see me. His current medications include, and I'm going to use brand names because I want to tell you exactly what he was taking. So he was taking Rosuva Gold, which is a combination tablet of rosuvastatin 20 milligrams, aspirin 75 milligrams, and clopidogrel 75 milligrams. He's taking Metosartan, which is a combination of metoprolol and telmisartan of 50 milligrams of metoprolol and 40 milligrams of telmisartan that he takes once a day. He takes Nicorandil 5 milligrams twice daily. So these are three medications, three tablets that he's on. Two of them are fixed dose combinations. So that is the current medication he's taking, asymptomatic. Labs I told you. And while this case would have been otherwise a simple case, I chose this to discuss few things which often come to our cardiology attention. So the discussion points are as follows: how to rationalize treatment regimen for this patient. He's taking these medications. For him, he just takes 4 tablets. He's doing fine. He doesn't have any active complaints. How do we rationalize treatment regimen for this particular patient? And how do we define the role of dual antiplatelet in long-term management of chronic coronary syndrome? And I say long-term management, particularly in these kind of cases. We can even say remote management, because he had a coronary event around 4 years ago. And since then, he had been doing reasonably okay. Then long-term management of long-term role of using beta blockers, ARB, nicorandil, and all this in this patient subset. And then lastly, this is a question more for us: can drug regimen in these kind of patient subset be safely de-escalated without paying any price in terms of any cardiovascular event and whatnot? Sometimes patients ask us this question, that can we reduce the medications? But I believe at times we should be asking ourselves this question as well, that are these medications even needed? And then if there is any error of omission, which means if there is any medication that he should be on, which we have not put him on. So Praneeth, how would you take up this case in terms of his medication regimen? How is he doing overall? Do you want to do any other investigations to help you make a decision? And answer the questions regarding dual antiplatelet, beta blocker, ARB, nicorandil, and whatnot in this particular case. Praneeth.
Yeah, good evening, everyone. So this patient, I'll look at as a patient who had coronary event when he was in his late 40s, at 48 years of age, smoker, and he had non-ST elevation MI. So I will consider this patient as someone who has high risk of ASCVD, probably more contributing by his smoking, but still I would consider him as high risk. And he underwent angioplasty and he is receiving all the drugs that I want him to take: the dual antiplatelet therapy, moderate to high intensity statin, beta blocker, and then RAS blockade, that is an ARB. Nicorandil is also there as an anti-anginal. So he is receiving all the drugs for his ASCVD. Now, 4 years down the line, when he comes to follow up, when he's apparently stable, I am actually happy with what he is doing up, where he quit his smoking. His numbers look okay, rates are fine, blood pressures are fine, ECG echo are good, and his lipids are also good, not diabetic. Now, firstly, I would be impressed by this patient that he is taking good care of himself. Now, going forward, what would I do to change his medication? Because I believe he is not having any angina and he's able to carry on his activities. I don't think there is any role for him to receive anti-anginal nicorandil. And so I would try to stop. And also we discussed in our last session about the role of nicorandil in various issues, from oral ulcers to ulcerations GI tract. But equally, I don't find any indication to continue nicorandil in him. So first I would stop this thing. Now, regarding dual antiplatelet therapy, the way I look at is whether the patient has any risk of bleeding versus the risk of ischemia. Being 52 years of age, I look at him as a low risk of bleeding. Unless he has any issues or is there any problem, I would be still okay continuing his dual antiplatelet therapy, understanding he will be equally okay with single antiplatelet therapy. The major challenge will be in terms of pill burden, and if all these things is combining in a single pill and patient is compliant and comfortable, I would be okay continuing dual antiplatelet therapy. Statins, high intensity statin for him, again because I consider him as a high risk patient, and now that his LDL cholesterol is 62 on 20 milligrams of rosuvastatin, the targets that we have to look into is having an LDL of 55 or less. This patient is having 62, so reasonably okay. So I would be still okay to continuing him on 20 milligrams of rosuvastatin. So this triple drug combination of dual antiplatelet therapy and statin, I would still advise him to continue the same. Regarding metoprolol and telmisartan combination, pressures are fine and he is doing okay. I would be again okay to continue this thing. Role of beta blockers on long term, unless he does not have any LV dysfunction, no angina, no heart failure. Role of beta blockers is of question, but when he is doing okay, I again will be okay to continue the metoprolol and telmisartan combination. If there are any side effects associated with beta blockers in terms of easy fatigability, impotence, or any other issues, then I would probably consider. Equally, personally, I am a bit hesitant or lack confidence in weaning beta blockers because of the risk of rebound hypertension and probably precipitating angina. So personally, I would continue both of them. So for this patient, I would stop nicorandil, continue Rosua Gold once and Metostatin once daily, two tablets a day probably will be okay. And de-escalating in a otherwise stable patient, I would be a bit hesitant in de-escalating because whatever regimen which was making him stable, unless he has any issues associated with it, I would still be okay continuing them unless there is any strong reason for me to de-escalate. That is my take on this patient, Anoop.
Pranit, any investigation at this point that we did not do that you would like to do?
Not that I can think of. I think that is the basic lab work that I would also order. Nothing that comes to my mind at this point of time.
And just so that we finish this discussion, although we are not talking about this today, but would you do any stress test on him?
No.
Okay, perfect. All right, the floor is open for discussion. If anybody has got any thoughts, please share. I will be asking my attendees about their opinion. And as I'm going through the list, I'm just going to pick up a few names. Let's see. Praveen is here with us. Dr. Praveen, if you can hear me, could you please unmute yourself and share what will you do with this patient?
Good evening, everyone. Sir, regarding this case, as the patient is stable and all that, I would be continuing the drug, sir, the Rosua Gold and all that. If we want to stop any of the drug, the first one would be a nicorandil. And the next one, I would concentrate in the follow-up of this patient. I would be seeing regarding the HbA1c. And if HbA1c is of slightly altered, and then I would be decreasing the dosage of metoprolol to 25 mg or even stopping it, sir. If there is any LV function is fine, then the de-escalating of the beta blocker would be fine. Why? Because this patient, he is a non-diabetic, and a long-term beta blocker of 50 mg can cause they can increase the risk of diabetes. In follow-up, I would be following with the HbA1c because it is 5.9 for him. If it is on the increasing trend, and then I would consider stopping the metoprolol or decreasing the metoprolol. Rest of the drugs, if patient is compliant, I would be continuing, sir. So first would be nicorandil and then decreasing the beta blocker.
So my question, Praveen, to you is, if you are worried about beta blocker, why not stop it now? Why to wait for A1C to go up?
Sir, what you call, it might not be seen in all the patients now, sir.
Right, it won't be seen in all the patient. That is correct. That is absolutely correct.
For the same reason, and at that time, the benefit would be more than that of the harm now, sir. So, and if the same patient has been controlled on continued on beta blockers, and his HbA1c is increasing, then the purpose of stopping the other drugs or continuing him on a single antiplatelet would not be making sense. Why? Because this patient profile will be changing. He is a diabetic now, so he will be falling into a high risk category compared to that of when he is now.
Perfect. Thank you, Praveen. We are going to discuss all of this. I'm going to take more opinion from my attendees. We have Dr. Prashant here with us. Prashant, if you can hear me, could you please unmute yourself and share your thoughts? Prashant, if you can hear me. Dr. Shankar, if this patient were to come to you, let's say, after 2 years of lost follow-up, and if you were to be making decisions for this patient, how would you approach this case?
Good evening to all. Looking at the history, we can say that this is a case of a chronic stable ischemic heart disease, coronary artery disease. Now it is defined as a chronic coronary syndrome, CCS. So more than 4 years passed post MI and PTCA. So we have to give antiplatelet agents in this case. We have to continue. So already for first 1 year, we give aspirin plus P2Y12 inhibitors. And after that, we'll decide, looking at the DAPT score and the precise DAPT score, whether this DAPT can be extended or not. Looking at this case, his DAPT score is more than 2. So he definitely needed a long DAPT, and that too more than 3 years we can give. So now it's a remote case, as already alluded to. So the lifelong antiplatelet agent here, I prefer to give only aspirin alone rather than combining dual antiplatelet agents, because already more than 4 years without any symptoms of angina. So regarding the antiplatelet agents, I will go for only single antiplatelet agent in this case, because more than 4 years without any symptoms. And second thing, I will go for statins. Statins, here his LDL is how much?
Sir, 62.
62. So LDL is 62. So according to the ESC or ACC guidelines, or even in Indian LAI, in this Lipid Association of India guidelines, so he comes under a very high risk group, because already established CVD is there. He had myocardial infarction and he underwent the PTC and all. So established CVD. So he comes under very high risk group, where is a target LDL should be less than 55 or 50 according to Indian guidelines. If it is less than 50 also, it will be very better. It will be better. So here is LDL is 62, nearing that, but still, if you want to strictly follow the guideline directed medical therapy, then rule of 6 we go. If you increase the dosage of rosuvastatin from 10 to 20, only 6% of reduction will be there in the LDL. So I increase the rosuvastatin from 10 to 20, single antiplatelet agent and rosuvastatin 20 milligrams, so that we'll get the target level of LDL. And regarding the beta blockers, they are highly effective in the reduction of symptoms of angina also, and development of the myocardial ischemia, and even in the stable patients. And it is efficacious and beneficial, especially in patients with myocardial infarction. So here the heart rate is also more than 60 beats per minute. So I continue beta blocker, even 50 milligrams also. The chances of diabetes is remote in this case, because his A1C is still 5.9, and Then the beta blocker has to be continued. Since he is hypertensive, the ARB, that is telmisartan, it will be continued. So I will stop. I will strictly ask him to stop smoking because he was earlier ex-smoker. So at any time he should not go for smoking. And nicorandil, there is no because the patient is not having any symptoms of angina, and nicorandil has got no role at all here. So nicorandil can be because nicorandil carries some side effects also, as I alluded to. So nicorandil, I will drop it here. Only single antiplatelet agent, rosuvastatin, I will increase it to 10 from 20. Then beta blocker, I will continue. And ARB, the telmisartan will be continued, and will stop nicorandil in this case.
Thank you so much, sir. We will continue our discussion. And before I invite Dr. Vijay Reddy for his thought process, I will just share with you the rationale of why I chose that this otherwise seemingly a regular case was worth discussing for an hour on this forum. So with this case, I have actually brought in a lot of questions. The question number one of dual antiplatelet agent. Now, back in the day when we discussed dual antiplatelet agent in the research trials, we discussed, we put in a binary number as 1 year. So we said less than 1 year versus more than 1 year. And then truly speaking, if you go back in the research in the last, I believe, 7-8 years, there had been two parallel researches going on. Two parallel set of researches going on. One research that is trying to reduce the duration of dual antiplatelet as much as possible. And most of those research using the newer generation stents, they do come in favor of shortening the dual antiplatelet duration. And then at the same time, there has been research data with prolonging the dual antiplatelet, the most famous being DAPT trial. And that also favors prolonging the dual antiplatelet therapy. So now it's almost like no matter how you test it, the hypothesis for which the research is done, that hypothesis proves correct no matter which way you test it. What we have learned over the period of time is it is okay to continue dual antiplatelet for a longer period of time, provided you think that the ischemic burden is high, provided you think that the ischemic risk is high and the bleeding risk is low. While there is some subjectivity to calculating this risk, actually the guidelines give us some objective criteria to define whether those risks can be calculated or not. But remember one thing, all these things, they are done when we say more than 1 year. What do we mean more than 1 year? Do we mean 2 years? Do we mean 3 years? Do we mean 4 years, 5 years, 10 years? I don't think research can ever answer this question. So while we are talking about year 1 through year 2 or maybe year 3, there is some data to help us. But what do we do on year 4, year 5, year 10? I don't think we have that kind of data set to guide us our therapy. And that is where our thought process and our understanding is going to work in these cases. The issue behind dual antiplatelet that I was told when I came to India a few years ago, and I asked my colleagues that why do we overprescribe dual antiplatelet? At that time, I thought that we overprescribe. I still think we do. And also, why do we favor single dose aspirin when we do of 150 milligram versus 75 milligrams, which is what is recommended worldwide? And the answer that I got, very pragmatic answer, may not stand the test of time, but the pragmatic answer I got was that Anoop, in India, with the quality control, if you are prescribing 75 milligrams of aspirin to a patient, you don't know whether the tablet contains 75 or whether the tablet contains 37. We have no idea. So when we give 150, we know at least the patient is getting anywhere from 75 to 150 milligrams. So we tend to err on the side of giving a little bit more than a little bit less. And the same thing goes for dual antiplatelet as well, that if you are giving 2 antiplatelet agent, then you know for sure that you are giving at least one antiplatelet agent, even if the drug quality is a little bit compromised. Now, that's a little bit more pragmatic way of looking at in the Indian context. Whether that is correct or not, I don't know. Whether we should be putting that kind of judgment or not, I don't know. So if this question was being discussed in a heavily regulated pharmaceutical market where quality control is taken care of, in those situations, after 4 years giving dual antiplatelet agent, I don't think there is any data that can support us to go either for or against. The scoring system like DAPT and whatnot, all of these are tested for the short term. Short term means after year 1 to maybe year 2, maybe year 3. But whether they apply to year 4, 5, 6, 10, I don't know. These things are just not clear. That is where I think discussion becomes important. Having said that, the idea of risk profiling this patient, Praneeth said and Shankar sir said that they would categorize this patient as high risk. I don't know. I wouldn't categorize this patient as high risk. And I am going by some of the criteria that has been defined by the guidelines, where there are actually some objective criteria to say what you will use to consider this patient as a high risk. Certainly an active smoker is a high risk. But once the patient quits smoking, how long it takes before this patient's baseline cardiovascular risk becomes similar to age-matched non-smoking peers. What time do you take? Do you take 6 months? Do you take 1 year? Do you take 5 years? Do you take 10 years? I don't know. There are some data point, again, hinting the same thing, that once you quit smoking, after how many years you can be considered at a similar risk profile as your age-matched peers who are non-smokers. What will that time be? I personally consider that as 1 year because I have read it in certain places. I don't think there will ever be any data set regarding it. So from my thought process, if a person has quit smoking 4 years ago, then from the cardiovascular risk standpoint, at this time, he is at the same risk as his non-smoking peers. That is my comprehension. Again, not based upon data set. The reason why I think the drugs that needs discussion for nicorandil, I think the consensus is pretty clear. But beta blocker also, about a decade ago, there was a discussion about what is the expiry period of beta blocker post-MI in an otherwise stable patient who does not have heart failure. And there was a lot of debate about what that expiry period is. A consensus statement was released a few years ago that 3 years is probably a good time, after which we should actively stop beta blocker unless there is an indication, which is ongoing angina or heart failure or arrhythmia or something of that sort. Again, these are consensus. We don't know. We have no idea about how the beta blocker thing works. But I think that continuing beta blocker for long period of time, we know not only with diabetes, beta blocker has effects in its metabolic parameters as well. Be it your cholesterol profile, be it your overall metabolism, be it your diabetes, beta blockers are not a long-term healthy drug as to speak. In fact, 2 decades ago, 1.5 decades ago, when hypertension was studied with beta blocker in one arm and calcium channel blocker with another arm, then there was actually higher mortality in beta blocker arm, understanding that was a hypertension arm, not a coronary disease arm. And the same thing that goes for ARBs as well. This patient's systolic pressure in my OPD is 106. At home, I don't expect his blood pressure to be more than 130, 140. And if we go by the hypertension data that has come so far, what we do know is when we start driving blood pressure below a certain limit, in sprint trial, that number was 130. There are many other trials where it has been, signal has been given that as we drive pressures low and low, it certainly reduces the cardiovascular and cerebrovascular events. The quantum of reduction is not much, but it certainly reduces. But it comes at a cost of higher incidence of CKD in these patients. As you all know, that kidneys require a little bit extra perfusion pressure as compared to heart and brain. So there is certainly an inflection point. If you drop blood pressure beyond that over a long period of time, unless you have an active reason like heart failure or whatnot, then these drugs, they may not be very benign. You may actually end up with these patients, more proportion of them developing nephropathy and whatnot may not be a very overt nephropathy, but they may develop, they may tend to be on a path of early CKD than a person who maintains their blood pressure at around 120/30 or so. So that is particularly the reason why I thought all these things, they are very important. Same thing is for statin as well. Because I thought this patient is not at the highest risk, I would have put him an LDL target of 70, but I wouldn't refute if somebody says my LDL target is 55 for this patient. We all know that for LDL, the whole idea of too low causing cerebrovascular events, that is not true now. You can actually drive LDL as low as possible. And if this patient is stabilized on rosuvastatin of 20 milligrams, might well be, but 62, in my opinion, was a very good number for him. And if somebody would have decided to bring down his rosuvastatin from 20 to 10, that also probably would not have been a bad option, bad decision in my option. And remember, statin on the long run, again, has been implicated with diabetes risk. And I have heard multiple seniors saying in India, again, there is no way to verify that what statin dose which has been standardized in the Western world, whether that is the same standardization we can use in Indian subset, that also is a debate, that also is a question for which we don't have an answer to. So whether 20 milligrams of rosuvastatin in a Caucasian male equates 20 milligrams of rosuvastatin in Indian male, that also we don't know. I'm talking more in terms of the metabolic derangement. So I thought there were enough reasons for me to discuss about medical therapy in these patients for long term, because at some point, it is possible that our therapy itself are causing more problem than actually benefiting patient. So that was my about 6 minutes rant of why I thought this case was relevant for me to discuss. I'll continue my discussion. I'll ask Dr. Vijay Reddy for his opinion on this particular case. Vijay sir.
Good evening, Anoop, and good evening, everybody. My thoughts on this patient. This is a 40-year-old man presented with NSTEMI. Now he is having stable CAD. So down the line, he is receiving dual antiplatelet drugs for the last 4 years, which is unwarranted. Usually DAP is recommended only for 1 year. And beyond that, beyond 1 year, up to 3 years, it can be recommended with high ischemic recess. That too is ticagrelor 60 milligrams, not with clopidogrel as proved in Pegasus trial. That is number one. So I will straight away remove this clopidogrel and start only aspirin. That is number one. And you told about this thing, smoking. When the patient stops smoking, after 2 years, he will become, the risk become non-smoker levels only after 2 years. That is number two. Number two, lifelong, there is only one indication for lifelong DAP. That is brachytherapy in a patient with in-stent stenosis. Here we have to give lifelong DAP. That is thing. Regarding regarding beta blocker, the idea when the patient is having normal LV function, the ideal duration is up to 3 years. Afterwards, there is no need for any beta blocker. Patient is not hypertensive and LV function is normal. So his hemodynamics are also borderline. He's having 106/66, no need of telmisartan also. Regarding rosuvastatin, I would still prefer to give 40 milligrams, though the recommended dose, he's achieved LDL of 62 with 20 milligrams. Because why I am recommending 40 milligrams of rosuvastatin, because he is a Indian, that too is a South Asian, is a high risk ethnicity. So I want to be his LDL less than 55. That is number one. Number four, nicorandil, straight away I will strike down in my prescription. So my order of preference is ecospirin, the 75 milligrams, rosuvastatin 40 milligrams, and no beta blocker, no telmisartan, no recanal, no nicorandil, and my target of LDL should be less than 55 with lifestyle modification. Over to Anoop.
Sir, one question before I let you go. If you choose single antiplatelet in this patient, why aspirin, why not clopidogrel?
Aspirin aspirin usually in India, we are having non-responders up to 30% with clopidogrel. And we are not doing any genetic this thing for this clopidogrel. So I prefer to use ecospirin rather than clopidogrel. We don't know the incidence of the clopidogrel non-responsiveness.
Thank you, sir. I concur with you regarding the choice of aspirin versus clopidogrel. In fact, that also had been a significant discussion in the past, that which agent we should choose as a single agent, where we know that aspirin at times is implicated in higher incidence of GI bleed in all these research trials, where people have actually started saying that aspirin may be the biggest villain as compared to the other drugs that we're talking about. But I concur with you that whenever we are putting these patients on single antiplatelet, and if that person ends up being a non-responder to clopidogrel, then now that person will be on no antiplatelet, as compared to when we are doing a dual antiplatelet. Even if the person is non-responder to clopidogrel, at least he's getting some aspirin, so he's getting some benefit. So I concur with you. Whenever I choose a single antiplatelet, I always prefer aspirin, unless there is a documented history of GI bleed or peptic ulcer disease, or a patient proves to be intolerant to aspirin, in which case I go to clopidogrel as a single agent. So,
and we are not doing routinely brachytherapy for instant stenosis. So there is no need for lifelong, we got a better ways of managing instant stenosis. Earlier, brachytherapy is very common in our scenario, and we have to use lifelong DAPT.
Right. The other setup, I think, where dual antiplatelet in the current context are kind of recommended, other than the obvious very high risk subset, which means patient who had more than one MI, or patient who had an MI while taking antiplatelet, or patient who had a multi-vessel PCI, who had a left main PCI, or a complicated bifurcation PCI, all those kind of things. One of the other patient subset which we may see are those patients who got absorbed biovascular scaffold back in the day. Because we know that biovascular scaffold, the first generation one that were used in India, they tend to have higher incidence of stent thrombosis going all the way up to 3 years. So in these kind of patients, even beyond 3 years, one would argue that giving dual antiplatelet therapy may be the right thing to do. The only exception would be in those cases where there is a proper angiographic and imaging evidence to say that the scaffold has been completely absorbed, and that there is no residual major disease that we are dealing with. So this, I believe, from the cardiology standpoint is more technical, but all the non-cardiologists who are practicing, if you do see patients who received absorbed in the past, then it may be a good idea to continue the dual antiplatelet, or at least ask your friend cardiologist in terms of whether it should be continued or not. So the floor is open for discussion. If anybody has got any questions, comments, anything to add, you can raise your hand or unmute yourself while I read some of the queries or comments which have been put on the chat box. So one of the comment is 15 years is what after which the risk of CVD is same as normal person without risk factors. Praveen, if it is 15 years, then I stand corrected. I always used to think that after 1 year you are back to where you started as far as CVD risk is concerned. If you don't mind, if you could please share that in the WhatsApp group so that we all can read through that.
Yes,
The other question.
okay.
Yeah, Praveen. Sorry.
Yes, sir. I will be sharing, sir. Actually, it is for one. That is what you call the. If any of the smoker has what you call quit smoking, at 1 year the risk will be decreasing by 33%, and that is 1/3, and then after 15 years only it will be becoming that of the patient without any risk factors. I will be sharing, sir.
Perfect. Thank you so much, Praveen. And Gauri ma'am, we'll come to you. I'm just reading some of the questions on the chat box, and then I'll come to you. And then Shankar sir, I'll come to you after that. The other question is how long one should give beta blocker in completely revascularized end STEMI with good LV function. Santosh, I think this was briefly discussed. And these are all opinion. I don't think there is strict guidelines. My opinion is 3 years. Remember, these are the patients who should not have heart failure, who should not have breakthrough angina, who should not have any arrhythmias or anything for which beta blocker is recommended. Remember, beta blocker, as the growing age in males, are hugely implicated in genitourinary obstruction symptoms as well. So I think beta blockers, when we look into the adverse risk profile, while we are very comfortable prescribing these medications, particularly in males age 50 and above, it can start causing problem if we don't have proper indication. One question that Praveen asked is, how comfortable is it to give the fixed dose combination versus individual drug? Praveen, this is a question that has been asked multiple times. I wanted to actually do a huddle program on it. I have no idea about this. In fact, the very first session, the very first 10 sessions of huddle, we actually had a very special guest in our huddle called Dinesh Thakur. He was a whistleblower in the famous Ranbaxy case. And he was there, and we had Dr. Harry from Cleveland Clinic, where we discussed about the quality control. And there we briefly touched upon fixed dose combination, or FDC. And the overall opinion of these guys who have been into quality control for quite some time, their overall opinion was that the FDC are literally just a toss of a coin. You absolutely have no idea how much drug is in there. And that is the reason why in patients who are fresh out of acute MI or stent, I typically tend to give them individual drugs for the first 3 months or 6 months before I switch them to FDC, because the comfort level with FDC is a little less. Most of my colleagues also share a similar thought, although they may be switching, maybe not after 6 months, maybe after 1 year. Some of my colleagues switch after a month. But the discomfort is there. I don't deny that, and I'm pretty sure most of my colleagues, they share a similar discomfort. Santosh asks, do we calculate DAPT score beyond 30 months? Santosh, we answered this question. DAPT score was recommended for this 30-month post first year, but I don't see a reason why we cannot calculate it. It is just that it is not studied in that per se. So its applicability is still in question. It may be valid, we just don't know that answer. Gauri ma'am, your comments, and after that we'll come to Shankar sir.
Thank you, sir. Thank you for giving me the opportunity. I had 2 things to say about maybe not exactly with this case, but relating to beta blockers. One is that I have seen patients in my clinic post. They have, as a physician, I see them as a follow-up when they have undergone, a stenting, or they have seen the cardiologist, and then they come for follow-up many times to the local clinic where the physician could be. And few things that they come up, which we have seen, is extreme fatigue as one of the symptoms, very common. The other is uric acid levels. I'm not sure what happened with this particular patient. Renal parameters seem to be normal, but I think that is something I have seen going high. And third is not as much talked about, definitely erectile dysfunction. So there has been a lot of talk about depression along with beta blockers, but not really. So a lot of meta-analysis say that it is really not associated. But then a lot of especially men between the age of say 45 to 60, where they have undergone, who have been on beta blockers post stenting or any event, right, cardiac event, they tend to show symptoms which could be because depressive symptoms, which could be either because of the fatigue or because of erectile dysfunction in Indian culture, because it's not spoken about as much. But this is a problem with beta blocker that I see very commonly when prescribed in men in this age group. And I just wanted to put it out there because I don't know how many patients talk about it or how that discussion happens, when they come for follow-ups. So that was one I wanted to bring to light. 2 is, has there been an upward trend of movement of the HbA1c itself? Though here it seems 5.9, I have also seen, as you mentioned, Dr. Anoop, that metabolic, there's a lot of these changes that can be seen. And I have seen rise in HbA1c, over like years of the patient being on a beta blocker, over a period of time. Now, is it because of the beta blocker itself or because of many other factors around it, which could be also adding to the fact that, sugars then later on present, which was not there before. So these are the few things that I have seen with regard to beta blocker. Otherwise, I concur whatever the discussion that has happened otherwise.
Ma'am, all your points are absolutely spot on, and I will share my comments a little bit, but let us hear from Dr. Shankar first. Shankar sir.
Good evening. Regarding smoking, we in the earlier huddle sessions we have discussed. So the timeline, when what happens when we quit smoking, in a chain smoker, within 20 minutes his heart rate and blood pressure drops, and within 24 hours his chance of heart attack also decrease, and after 1 year the risk of heart disease drops to half that of a non-smoker, and over a period of 15 years is almost the risk of heart disease is that of a non-smoker. So 15 years. What Dr. Nagula Praveen told is correct. We can give the reference also regarding this. And the second point, see, everybody is talking about the beta blocker stoppage, but the beta blockers should not be stopped abruptly. That everybody knows about it. But what is the experience of the audience, the August audience regarding this stopping beta blockers abruptly? Because in the literature it is told that the sudden surge in the sympathetic activity and precipitation of the angina in case in CAD patients. So sudden abrupt stoppage of beta blockers is not advised. If at all, if you want to reduce it slowly, we can reduce it from 50 to 25 we can make, because his blood pressure is 106/64. So we can reduce both the drugs like ARB and beta blocker to the half the dose. I will wait for the opinion of Dr. Somaraju sir, his vast experience.
Thank you, Shankar sir. I'll just add two comments and then we will go to Somaraju sir for his opinion. So, Gauri ma'am, your points were absolutely well taken. Beta blocker has been implicated with this chronic fatigue syndrome, and many patients, they actually learn to live with it. This is particularly problematic in middle-aged adults, and also the erectile dysfunction and whatnot you mentioned. I think we all kind of tend to see that, but it is just that cardiology visits are so much at times focused on cardiology that these things, they do get missed. So by no means I want to discount beta blockers. They are great drugs, and in fact in cardiovascular space they have really transformed how we treat patients. It has increased our comfort level in how we prescribe beta blocker, and I believe it is because of this extra comfort. Sometimes we tend to overzealously prescribe this even in those patients where other drugs may probably do an equally good job. And Shankar sir, I agree with you. Beta blocker withdrawal is a real thing. Particularly if somebody is on beta blocker for quite some time, then it's a real problem. This particularly happens very prominently in hydrophilic beta blockers like atenolol, but even lipophilic beta blockers, we see it very commonly. And we tend to reduce beta blockers slowly in those patients who have been on chronic use. I will tell you what I did with this patient myself, and then we'll go to Somaraju sir for his opinion. So I stopped his nicorandil. I think that was a general consensus amongst all the discussants today. I reduced his metoprolol to 25 milligrams once a day with the intention to stop it after a month, which I told him that you only take it for a month, send me your vitals and I'll tell you to stop it later on. I continued his telmisartan, but I reduced it to 20 milligrams, and my intention was to continue telmisartan for quite some time. And only when I would see how his blood pressure would respond to all these things, because I didn't want him to get into a hypertensive episode. And only when I was okay with his blood pressure, I would either drop telmisartan or continue 20 milligrams for some time, depending upon how his blood pressure would do. I did continue his Rosuva Gold 20 milligrams, and I shared with you my rationale of doing it. I continued 20. I did not increase it to 40 because I thought 62 was a good enough number for him. And I continued dual antiplatelet, not particularly because there is an indication for dual antiplatelet, but because of the learning I got from the very beginning that quality control of drugs are a big problem for us. So if I give him 2 drugs, I at least know he's getting at least 1, if not 2. So I know at least he's getting some antiplatelet agent. So it is more of a little bit of more pragmatic way of looking at it, not a scientific way of looking at it. But I did continue his fixed dose combination of rosuvastatin and 2 antiplatelets, 25 milligrams of metoprolol and 25 milligrams of telmisartan and 20 milligrams of telmisartan. That's what I did with the intention to stop metoprolol after a month. So let us see what Somaraju sir has to share his thoughts, and then we can continue our discussion for about 5-7 more minutes. Somaraju sir.
Thank you, Anoop, and good evening to everybody. And so number one, I just want to ask, was there a family history of diabetes in this patient?
Sir, there was no family history of diabetes.
Okay, if there is no family history of diabetes, it's important to know. And second thing is, not a word is spoken about him as a person. What does he do? And what is his physical activity? What is his work and work environment? Do you think these things matter?
Yes, sir, these things matter. It is just that we wanted to limit our discussion to the particular.
Nothing,
yes.
There's nothing like the person-centered medicine versus disease-centered medicine. Please, you have to come out of it. I leave it at that. Keep it to yourself, and let us not discuss more about it. Having said that, I agree with smoking cessation. The risk goes on coming down from the day you stop smoking, but it takes 15 years. By the end of 15 years, this person is as if he never smoked. That is the data available, actually. And second thing is, when he had the first acute coronary syndrome, he was a young active smoker. And his coronary anatomy, rest of the coronary artery anatomy is important to know. That would decide as to what we continue, how much we continue, etc. Whether if there is no family history of diabetes, the diabetes may have been contributed more likely by statins than small dose of beta blocker, or combination. Both of them could have contributed. Keep that in mind. And I think overall, to try to young active smoker, if the lesion at that time was a thrombus dominantly and rest of the coronaries were otherwise normal, to continue antiplatelets forever probably was not a right decision. And this diabetes possibly is related to his lifestyle or the drugs he was taking, etc. But I'd like to know his physical. Somebody said there's no need to do functional testing. But somebody who is physically active, regularly exercising, versus somebody who is physically inactive, never exercises, they are different. The indications for functional testing, etc., are different in them. Thank you.
Sir, one question that we wanted your opinion on is this fixed dose combination. When we don't have data, we rely upon experience. What is your thought about fixed dose? Do you personally think that of the available fixed dose combinations, they work less efficiently than the individual components?
Thank you for asking that. There are 2 components to it. I never prescribe it myself. If somebody already prescribed, they are continuing. Sometimes I continue, sometimes we change. And the absorption of the drugs in fixed dose combination is doubtful. And bioavailability is already There were some publications already available that it's not up to the mark. Secondly, these fixed dose combinations also produce significant acid peptic symptoms. When you divide them, they do well actually into separate drugs. Thank you.
Thank you so much, sir. Gauri ma'am, you have something to add?
I have just 30 seconds with regards to fixed drug doses, and this is a normal GP problem that we have. There are two reasons why patients come back and they say that, ma'am, there are too many medicines that I'm taking. Can you reduce the number of pills? You know, this is one question which comes very often in the clinic. The second thing that comes is, ma'am, this is becoming too expensive. When there are too many, when you do single drug, the cost goes high, and that's what. And sometimes these are the two reasons why we at times choose to do combination medicines. You know, ideally, I do not like to combine, but there are these two reasons very commonly that patients come forward and say, which then you have to think about the patient and then maybe take that step at times. Just wanted to add that.
Thank you so much, ma'am. In fact, I got training in a situation where fixed dose combinations were never a part of prescription. But over the years, I have actually gone through what is the evolving knowledge, both in the Indian as well as in the Western literature. And European countries as well as US and India, it's pretty much established that there is a certain inclination towards fixed dose combination. Quality control is a separate issue altogether, but there is certainly an inclination towards fixed dose combination. In fact, there is data in the hypertension world showing that fixed dose combinations are more efficacious than the same drugs given independently. And of course, the only way you can explain is compliance, nothing else. There is no reason why fixed dose combination will actually work better than taking two different tablets together. And the only way you can explain it is compliance. There is actually European data about it. We have been using it in India for quite some time. WHO is advocating it using in developing countries like Africa and whatnot. And in the hypertension world, there are actually guidelines which are supporting use of fixed dose combination over individual drugs in these patient subset. The risks have been already described, which is the bioavailability of taking these many drugs together, how they are bounded together in a single pill, their relation with gastritis symptoms, because now you are taking multiple drugs at the same time. So all of these, they have been described. But I believe the benefits that Gauri ma'am mentioned and what the guidelines are also mentioning in terms of compliance, cost and whatnot, that also have to be taken into account, and the overall result becomes so complex that we often have to put our own individual judgment when we are dealing with these patients. That is why I told you like what I do and most of my colleagues do, which is after an index procedure, when we know the medication are very critical, there we tend to give individual drugs as compared to people who are in the remote, who had a remote event. There we are far more comfortable giving a fixed dose combination, even if there is a quality control issue. The other thing what also I think needs to be brought out when we talk about quality control is sometimes these tablets not dissolving in the stomach or in the gut. And there are at times where patients, they do come to us reporting that they are actually excreting a solid tablet, solid pills in their stool. It is important, in fact, it is embarrassing, but it is important for us to know which of these tablets are being excreted in the stool, because if let's say you did an angioplasty in a patient 2 weeks back, and if that patient is excreting ticagrelor as their tablet in the stool, that means effectively there is no ticagrelor going into the body, and these patients are unnecessarily at higher risk or highest risk of stent thrombosis. So that is also something which we should regard, particularly with the fixed dose combination, because there if one tablet does not dissolve, then that means effectively patient is not getting 2 or 3, whatever that combination of polypill is. The patient will be devoid of that medication. So very complex issue, and I wish we had better answers for this, and we have to use our own thought process. Somaraju sir mentioned about his index angiogram. Sir, I didn't have his CD with me, but I had his report. and the report mentioned all the other arteries being normal. Now, whenever somebody mentions normal in the arteries, I always take it with a pinch of salt. I actually want to see the angiogram myself, because many of the times mild diseases are reported as normal. These are important for us to know, because we know that these mild disease may progress in the future. Unfortunately, in this case, I only had the access to report, not the angiogram per se. And this is also important for our physician colleagues, that whenever you are talking about de-escalating antiplatelet therapy, a word with the cardiologist becomes very important, because it is not just about the duration of the event. It is also related to what kind of stent was placed, what size was it placed, where was it placed, what was the rest of the anatomy. All of these, they do help us determine whether the patient should be on long-term dual antiplatelet or not. So if you plan to de-escalate an antiplatelet agent, just giving a call or looking into looking into the old cardiology recommendation may be a good place to start with. So I think with this, we can pause our today's discussion, unless somebody has got any particular questions. Maybe we can pause for just a few seconds. If somebody has any question, they can put up. And Gauri ma'am, thank you. You put in that PDF link on our chat box regarding list of banned FDC by CDSCO. I just want to add, I have seen this list many times before. I just want to add what is happening with this list. You know, the drugs which are banned in this list are actually the kind of FDCs which should not exist to begin with. Like there are FDCs in this list which has got a PPI combined with a NSAID. And you would think that why would there be a polypill existing with a pantoprazole and a ibuprofen? And some company guy must have thought that ibuprofen may cause gastritis, so might well put a PPI so that one pill will do both the job. That marketing guy probably didn't realize that one of the drug needs to be taken before food and one of the drug needs to be taken after food. So how can you have a polypill with that kind of combination? So CDSCO actually banned a lot of these combinations, which are obviously, which should not exist. Not that they have a quality control problem, they just should not exist. Amongst the existing FDCs, what kind of quality we have got, what kind of dissolution parameters they pass through, we have absolutely no idea. And if anybody is interested, they can go back and look into our drug quality control huddle discussion that we had in the very early phase. It's in a two-part series. The first part, we talk more clinical, where Dr. Harry is doing most of the talking. He's a cardiologist from Cleveland. And in the second part, we discussed with Dinesh Thakur. He's a whistleblower, essentially. He just had been a part of Ranbaxy scientific team. And later on, he was the whistleblower for it. So he talks about the quality control and what we do and all this. So with that, I would like to conclude, unless we have any more discussion points. Praneeth, your closing comments about today's discussion?
Yeah, fairly simple topic to begin with, but there's a lot to unpack in this fairly simple day-to-day clinical case, if I have to say. And the point that earlier mentioned, that rather than just looking at whether the patient is taking the so-called set of guideline-directed medical therapy, it is worth paying attention and sometimes pausing and seeing whether the drugs that we are prescribing over the years, is it actually doing any harm or benefit? And when there is this so-called risk-benefit analysis that need to be done, taking the patient's requirements into consideration, probably talking to him and educating about the risk and benefits of these drugs probably is vital. And according to the requirements, we may be okay taking a careful call on de-escalating the therapy, provided the patient is under close follow-up. And when you think that it is not so okay, it is fine to play safe and continue the therapy without being guilty about having an event now that you have de-escalated therapy. So I think each and every decision has to be individualized, and taking patient into consideration is always crucial in when we make these decisions. And very valid discussion that was brought up in terms of long-term usage of beta blockers, statins, RAS blockades, etc. And I think that was an excellent discussion that we had, Anoop.
Thank you, Praneeth, and thank you everyone for attending today's discussion and participating with your thoughts. We'll see you all next Wednesday with a new topic. If you do have a topic that you think we should be discussing in our future huddle, please share with us on the WhatsApp group, and we'll try to include it in our future discussion. Thank you all again for your an hour of time, more than an hour of time. We'll see you next Wednesday. Good night.